Okay, so I'm just going to give you guys a presentation on antepartum hemorrhage. I will include my references at the end when I send the presentation if you guys want to read up more. But yeah, so I'm just want to move. Okay, there we go. Okay, so when we define antepartum hemorrhage, it is usually defined as bleeding from or into the genital tract, and this occurs after 24 weeks of pregnancy, but this is prior to second stage of labor. If you have bleeding before 24 weeks, it is a miscarriage, and if there's bleeding after the second stage of labor, it's usually a postpartum hemorrhage. So antepartum hemorrhages, there's usually many causes, but they try to classify it whether it is from the genital tract, whether it's non-genital causes, and then the genital causes are also classified into extraplacental causes versus placental causes, and then your unexplained group, which is usually the most common, and the patients that present with antepartum hemorrhage most of the time don't have a reason why they are bleeding. So your non-genital causes would be your thrombocytopenic patients or your patients on anticoagulation therapy. And then your genital causes, extraplacental, will be your local, so usually from the cervix, when the patient is known of CA cervix, whether there's cervicitis, whether they have cervical polyps, if there's local trauma to the area, or if there's varicose veins in the area. Your placental causes will be your abruptia versus your placenta previa. And then we also have the small group of vasa previa, which is not very common, but it can be catastrophic for the babies. And then the placenta previa and the abruptia placenta is the most important causes. It's not necessarily the most common, but it is the most important ones, as this can have the most effect on the babies. Okay. Then for any patient presenting with antepartum hemorrhage, there is a general management that will lead you to the diagnosis of the cause of the bleeding. So all of the patients will start with having IV fluid. We have IV fluids up. We'll assess the blood loss, and we'll also check the fetal heartbeat. This is done with abdominal examination as well as ultrasound examination. And then important things to consider during this time is there any signs of maternal compromise? Is there fetal distress? What is the fetal maturity? If there's any abnormalities in the fetus itself that's causing the bleeding, and whether the patient is in labor or not. But we'll go into the management of each one specifically as well. So when we define placenta previa, it occurs when the placenta implants in the lower segment of the uterus, and this is usually resulting in complete or partial covering of the internal os of the cervix with the placenta. So if you break down the word, previa means, so it's pre means before or first, and then via means in the way. So placenta previa literally means placenta in the way. So it means the placenta is in the way of the baby being delivered through the cervical os. So when we look at why this is happening, so it's usually when the placenta implants in the lower segment of the uterus, and when the lower segment then further develops, there's disruption of the placental vessels. So the development of the lower segment usually happens between 26 and 32 weeks of pregnancy, and that's most of the time when you will see the bleeding from placenta previa. So placenta previa, the symptoms are very specific. So it's painless bleeding. So if there's any form of pain, it is not placenta previa. So it is painless, bright red blood. There's a sudden onset of the bleeding, and it's after 20 weeks of gestation. It can be intermittent or it can be continuous. Intermittent can be every time there's a development, a new vessel tears, and that's causing bleeding, where continuous is when it's more catastrophic bleeding from multiple vessels that have torn. So then your risk factors for placenta previa, it's when the upper uterus is not well vascularized. There's a previous C-section. if there's uterine surgery, if there's abortions, or if multiparity. The upper uterus is usually not, the upper uterus is usually not well vascularized, and this causes the placenta to implant in the area that is better vascularized, and in this case it would be the lower segment. If there's multiple fetuses, so if there's multiple placentas, it's a fight for space in the uterus. One placenta might implant in the upper part of the uterus, with the second placenta then implanting in the lower segment. Or in the case of monochorionic twin pregnancies, the placenta is usually larger, so then it can implant in the upper segment, but it will extend into the lower segment. Other risk factors would be your advanced maternal age, which is basically a risk factor for anything in pregnancy, as well as smoking due to the vasoconstriction of the upper uterus, which is then less well vascularized, or your intrauterine fibroids. Same situation as the twin pregnancies, there's a fight for space. If the fibroid is in the upper part of the uterus, the placenta will implant in the lower segment. So then your types of placenta previa, you will get complete, partial, or marginal. Important with marginal is to differentiate between a marginal placenta previa versus a low-lying placenta previa. So your marginal placenta previa, the placental edge will be within 2 centimeters of the internal os of the cervix, where with your low-lying placenta, it will not be within 2 centimeters, but it will be in the lower segment. Your complete placenta previa is when the internal os is completely covered by your placenta, and this is a contraindication for a normal vaginal delivery. Where your partial placenta previa, only a part of the internal os is covered, and this will be risk versus benefit for NBD versus Caesar. So your complications that's associated with placenta previa, you can have preterm labor, which is the most common. Preterm labor is also associated with preterm birth then of the baby, because they come early, they have low birth weight, they have a longer duration in hospital. This can be due to the complications like low APGAR with hypoxia, or it can simply be because they are tiny. Then also on the maternal side of it, patient can have hemodynamic compromise due to the bleeding. They are at increased risk of postpartum hemorrhage. And then there's also association between placenta previa and a placenta accreta. So placenta accreta is when the placenta invades the myometrium. The reason for the association is because the lower segment of the uterus is much thinner than the upper segment of the uterus. So when the placenta invades the myometrium, it usually attaches more firmly, and then there's problems when it needs to loosen from the uterine wall during placental delivery. So there is obviously stages or classifications for this. So we'll have the normal placenta, where the placenta attaches to the endometrium, which is then attached to the uterus. Or you'll have placenta accreta, where the placenta attaches through the endometrium directly into the uterine wall. Placenta increta is when it invades into the uterine wall further than placenta accreta. And placenta precreta, which is the most severe cause, is when it completely transcends the uterine wall, and then it can attach to the other organs in the area, and it causes massive hemorrhage. These patients most likely will end up with a hysterectomy. But yeah, that's the most extreme form, and it's likely also the most rare one. But yeah, as we said, it is associated with placenta previa because the lower segment is so thin. Then, so when we get to the management of placenta previa, the general management accounts for everything. So what is important to realize during the general management of antepartum hemorrhage is nowhere do they mention doing a PV examination. So they do start with doing IV fluids. So IV fluids are your crystalloids, which is most of the time Ringer's lactate. They on EM guidance, they do mention if the patient is stable, we do 1 IV line. If the patient has any signs of hemodynamic compromise, we will do 2 IV lines. And then while putting up your IV line, it's easy to do the bloods for blood gas, FVC and UNE to see your HB, but also to assist in for theatre, INR and PTT to assess your coagulation status, and then to do a cross match. If you see that on the blood gas the HB is low, it is important to order the blood to get the blood products, because it just makes the process faster rather than to wait for the patient to get to gynae and then for them to initiate ordering of the blood. So especially if there is an ongoing hemorrhage, it's better to get the blood to start it as soon as possible, because you also don't want to hemodilute the patient with crystalloids. Okay. So then step 2 would be to quantify the amount of blood loss. If there is any sign of hemodynamic compromise, so this can even be just a tachycardia in a patient, it is a massive hemorrhage until proven otherwise, and it's treated as a massive hemorrhage until proven otherwise. So for your massive hemorrhage, that would be bleeding more than 1 liter or any sign of circulatory shock. If there is bleeding that I quantify as 50 to 1 liter, which is a big range, so it's quite difficult to estimate the exact amount of blood loss, but that's usually when they try and quantify it based on what the patient says. It will be less than 1 pad would be a minor hemorrhage. If the patient has only used 1 blood pad, or there's blood in 1 pad only, it's a minor hemorrhage. If they've used if they've used more than 1 pad, it is a major hemorrhage. If there's signs of collapse, it's a massive hemorrhage. Patients do also come to hospital for spotting only, but it is important to realize that spotting can be a placenta previa. So proper assessment of these patients are important. So yeah, and then step 3 would be your focus. There's a 3-point assessment for your focus. You will do your fetal heartbeat, and this you want quality and quantity. Quality can be quite difficult on the ultrasound, as every time you move the probe a little bit, it will give you a different quality. But what is important is to recognize whether there is a good fetal heartbeat audible, and also if there's any fetal tachycardia or fetal bradycardia. You also then want to estimate the fetal weight as well as the estimated gestational age of the baby, as this will influence the management going further. And then you will look at presence of placenta previa on the sonar. So that will be the placenta covering the cervix. Do not do a PV before placenta previa has been excluded, as if you do the PV, you can cause a catastrophic bleed from the placenta. So this is what a placenta previa would look like on a sonar. So what you can see here is you will see the fetal head with the placenta in the way of the cervix. So in this case, this will be a complete placenta previa. Okay. So then step 4, call for help. So this doesn't mean help on the floor. Help on the floor should have been called from the beginning, from where you see a patient with PV bleeding. If there's anything that concerns you, you call help on the floor. This help means your neonatologist, your obstetricians, your blood bank, consultant if you need your consultant to come in. And then the obstetric management is just for interest if you wanted to know what their plan forward is. So this is the protocol that is on EM guidance for the obstetricians to manage placenta previa further. So if the patient is less than 37 weeks, they all get admitted. What's important is that we monitor the HB. So if the HB is less than 10, they do recommend blood transfusion. But then what is important is the moment the patient needs a blood transfusion, they are labeled as being unstable and they need to go for emergency C-section. If the HB remains above 10, patient does not need a blood transfusion. What they'll do is they'll do fetal kick charts to assess for fetal movement, and they'll also do CTG monitoring in the patient, and they'll plan for C-section delivery at 35 to 37 weeks. If the patient is less than 34 weeks, or if the fetus is estimated at less than 34 weeks, we need to do steroids for lung maturity. Then if the patient is more than 37 weeks, so more than 37 weeks will be a delivery. It just depends on how we're going to deliver. If the placenta covers the cervix completely on the sonar, they will have a C-section. If the placenta does not completely cover the cervix, or if they are feeling brave, they take the patient up to theatre, they do the PV exam in theatre, and if they cannot feel the placenta in the cervix, then they will augment and they will deliver. But this is very risky, so usually they will just send the patients for elective C-sections. These patients are at high risk for PPH, which is also something to keep in mind during the C-section, as well as if you're going to do an NVD. So these patients would, if you're doing the C-section, there should be absolutely no bleeding. The uterus should be completely contracted. There's no maybes or ifs. Yeah, you need to completely be happy with your C-section before closing the station to ensure that there is no PPH. Okay, so this is just a nice summary that I found based on placenta previa. So as we said, it's the placenta that implants in the lower uterus, and then there's levels of how it covers the internal cervical os. It causes painless, bright red bleeding, and there's increased risk of preterm birth and fetal hypoxia. So onto the next big group, which is your placenta abruptia, and this is defined as the premature separation of the placenta from the uterus. This is also after 20 weeks of gestation. It is not a common occurrence, but it is a very significant occurrence when it does happen. So the placenta can either separate completely or partially from the uterine lining, and then it causes hemorrhage. Important in placenta previa, not all bleeding is seen. Placenta abruptia. So then your classification of placenta abruptia, it is either classified as a partial or a complete abruptia. And this has to do with where the abruptia occurs. If it is a central abruptia, these are more inclined to be a partial abruptia. So central means it is like in the middle of the placenta, and it creates a pocket of blood, and these are usually your concealed abruptures. Where with your marginal, it is near the edges of the placenta. These tend to be complete due to it causes detachment of one edge, and then it basically spreads over onto the other edge. And these are apparent abruptia or revealed abruptia placentas because they present with vaginal bleeding. So just how placental abruptia usually occurs, there's rupture of maternal vessels that anchor the placenta to the uterine wall. 99% of the time, it's the maternal vessels that separate. 1% of the time, it can be the fetal vessels in the placenta, but this is very rare. Blood does then accumulate in the decidiobasalis layer, which then causes the separation. The blood forms a mass effect, causing the separation to happen and causing more vessels to separate, and this causes obviously a more mass effect until there's a complete separation of the placenta from the uterus. Then the separated section does not take place in nutrient exchange or gaseous exchange. So now that part of the placenta is ineffective, so the rest of the placenta needs to basically compensate. But when the separation is significant enough for the compensation to not be able to take place, that is usually when we'll see the fetal compromise and even the maternal compromise. So your risk factors associated with placental abruptia. So these are 99% of the time, it's maternal hypertension causing the abruptures, but there's also other causes that can lead to it. So your extremes of age would be your advanced maternal age. As I said, that's risk factor for anything. Your age less than 20 is also a risk factor for your abruptious. Multiparity, and then your substance abuse, like your cigarette smoking, illicit drugs like cocaine and meth, and alcohol consumption. And this is due to the vasoconstriction effect that causes inadequate supply from the maternal side, which then causes, and these vessels are also more weak, and this causes the separation between the two layers. Maternal trauma is also, it's basically a shear effect. So the trauma causes the vessels on the maternal side to literally break off from the rest of the placenta. Then the pregnancy related or the fetal related, with your short umbilical cord, because the placenta is attached to the upper segment of the uterus, when the baby starts descending, when the fetus starts descending into like the lower segment into the birth canal, the short umbilical cord cannot reach, and then gravity is causing the weak part to break down, and the weak part is usually the maternal vessels. If there is sudden decompression of the uterus, this would be your twin pregnancies. When one twin is delivered, there's a sudden decompression, and then weak part once again is the maternal vessels. Other sudden decompression would be your rupture of membranes. So yeah, when rupturing of membranes and you see blood PV, there is other causes, but placental abruption should be high up on your list of why you're seeing the bleeding. Something like a previous placental abruption will put you at higher risk of having an abruption again. And then prolonged rupture of membranes, which is associated with a chorioamnionitis. This will cause actually the placental part of the fetal part of the placenta to share from the maternal side. So this is that 1% where it's actually on the fetal side where the separation happens, and that is because of the infection that's causing the vessels on the fetal side to be weak. So your clinical classifications of abruption placenta is based on, so it's basically the signs that you have picked up and the symptoms. So important to notice here, no PV bleeding does not exclude a severe class 3 placental abruption. If there is no PV bleeding, but all the other signs, it is still a class 3 placental abruption. It's just a concealed one. So PV bleeding can assist you if it is there, but if it's not there, do not exclude the diagnosis. Do not underestimate the severity of the diagnosis. So more importantly is when you have your uterine tenderness. So if you have a slightly tender uterus, it is a class 1, and you do have more time in these ones, but it's still an abruption placenta that can rapidly progress to a class 3. In a class 3, you will have your very painful tetanic uterus. So this means that the uterus is contracting and there is no relaxation between the contractions. So these are the patients that present with the rock hard abdomen, very painful, and these ones can present rock hard abdomen, very painful with no PV bleeding. So then between your slightly tender uterus and your very painful tetanic uterus, you have your in-betweens, which is your moderate to severe uterine tenderness, and then there's possible tetanic contractions, but it can also just be tenderness without having contractions. You also then have your normal maternal BPs, your normal heart rate, versus your maternal shock. So when we talk about stable patients, it will be your class 1. So these are the ones that get the 1 IV line. But then class 2 and class 3, there's any sign of maternal compromise. That's usually when you'll have your 2 IV lines with your fluid, and you also assess whether you need to transfuse blood or not. Your fetal distress also determines which class you are, where we have no fetal distress versus fetal death, and then your fetal distress is in class 2. Coagulopathy also plays a big part, and if there's any signs of coagulopathy, this patient is a class 3 placental abruption. The class 0 is the ones that are diagnosed retrospectively. These are the patients that you have an elective Caesar booked, you take, for whatever reason, you take your patient to theatre, you do the Caesar, and then you pick up the retroplacental clot, a mottling on the uterus, or any of those signs, and these are your class 0 placental abruptures. These are difficult to determine exactly when the abrupture happened, because sometimes it can be a concealed abrupture that is not significant, that has sealed itself off, and that the rest of the placenta can still provide significant support to the fetus. So important, as I said, abrupture placenta is a clinical diagnosis. Do not depend on your ultrasound findings. It is a clinical diagnosis. So, sorry, the meeting is going to end in 10 minutes. Sorry. The clinical diagnosis is based
That's okay. You've got 9, so talk a little faster.
Okay. The clinical diagnosis is based on your history and your examination, and that is that's the things you use to put your patients in class 1 to class 3. So then once again, your general management, you have your IV fluids, your blood loss, your fetal heartbeat. So these are the same as with the previous, with the placenta previa, where you have your IV fluids, and then you take your bloods and you determine your HB. You use the bloods to see if there's any coagulopathy, whether you need to order blood products as well, and then also the ones needed for theatre. You do your cross match and you order if necessary. Step 2, quantify your amount of blood loss, but as I said with abrupture placenta, this is not the biggest thing. Important is whether the patient shows signs of circulatory compromise or not. And then step 3 would be your focus, which is your 3-point assessment, your fetal heartbeat, quantity and quality again. You want to hear a good fetal heartbeat, and you also want to see whether there's fetal bradycardia, fetal tachycardia. You need to estimate your fetal weight, and this is very important in abrupture placenta as this determines your steps forward. And then also when you do your focus, you can see the presence of placental abrupture. So there is many ultrasound findings, but because it is not a clinical diagnosis, it is a clinical diagnosis, not a diagnosis based on ultrasound findings. I'm only going to show you the 3 most important ones that we tend to pick up. So we have your retroplacental hematoma. These are the, most of the time it's in your concealed placental abruptures, where you'll have the retroplacental hematoma. So you can see here, this is your fetal head with your placenta, and then you can see this massive hematoma. The appearance of the hematoma will depend on when it happens. So whether it's echogenetic or not, will depend on when the abrupture happened. And then you also have your uterine wall there. So you can see the separation there. On this one, you can see your hematoma, and then there's your uterine wall, and you can see there's complete separation. Then the second part is your organized intrauterine hematoma. These are the ones that will present with your margin, or these are your marginal abruptures, where the bleeding is on the sides. If the bleeding extends behind the placenta as well, you will see your retroplacental clot, but most of the time you will see an organized intrauterine hematoma. And this is also a sign that the bleeding has happened. It's not an immediate bleeding, it has happened a while ago. And these are usually the patients that will present with compromise, with fetal demise. And these are severe findings. And then in this one, sorry, I couldn't find a picture of bigger twins, because usually you don't see them in the same ultrasound frame. But
not a big deal, because it's not something we see in the ED all the time. So don't spend too much time on this one.
You can basically see the hemorrhage in the membrane there. This is usually just a thin line. Okay, so then your management of placental abrupture. Step 4 would be to call for help. Once again, this is your obstetricians, your neonatologists, because these babies if they are delivered, these babies tend to be very small. Blood bank, because if it's a massive hemorrhage, you do need to activate your massive transfusion protocols in these patients. So if the fetus is alive based on your sonar, and your expected weight is more than 900 grams, we do an emergency C-section. If the fetus is less than 900 grams, these are also like dependent hospital to hospital. Each hospital has a different protocol based on the support they can give a fetus, but generally it's accepted as 900 grams. If the expected weight is less than 900 grams, we actually do not think this baby is going to survive. So they do rupture membranes, they augment labor, and they actually push for an NVD delivery. If the fetus is deceased, it does need to be an urgent delivery, but an NVD is preferred in these cases. Just important, with placental abruption, it is associated with uterine rupture. So if you're going to augment labor, you do need to have a high index of suspicion for uterine rupture, as that is a risk factor. So then onto the small group, but still very important one, your vasa previas. So previa once again means in the way of, and vasa means vessels. So these are vessels in the way of the baby. So it's usually present when unprotected fetal vessels transverse, sorry for that spelling mistake, transverse the fetal membrane over the internal cervical os. And so you get two types. You get your type 1, which is when there is unprotected vessels, which means there's no water and jelly protecting the fetal vessels, and that is between the umbilical cord and the placenta. So that will be your placenta on one side of your uterus, the unprotected vessels transversing the cervical os, and then your umbilical cord on the other side of the uterus. Or your type 2, where there's actually an accessory lobe of the placenta, where your placenta and your umbilical cord will have normal attachments to each other, but with the accessory lobe, there's unprotected fetal vessels transversing the cervical os. So this is what you expect or suspected when there's passage of dark blood per vagina, when there's rupture of membrane. If the blood loss is less than 300 mils, if there was a low-lying placenta diagnosed during the antenatal screening, and this is also when your mother is usually hemodynamically stable, but the fetus is actually showing compromise. And that is because the bleeding is all coming from the fetal blood vessels. And then with your uterine rupture, and this is actually defined as a separation of all layers of the uterine wall, including the serosa. If there's no disruption in the serosa, it is a uterine dehiscence. And this is usually when there's abnormal communication. So the uterus is completely separated, and there's communication between the uterine cavity with the fetus and the peritoneal cavity. Risk factors for a uterine rupture would be your previous C-section, especially if there's a classical scar. The classical scar, even if it's classical on the skin, doesn't mean it's classical on the uterus. But if there is a classical scar on the uterus, it is a very high risk for uterine rupture. If there was previous CPD, the patient is also at high risk. Previous evacuation of the uterus, because when they do the scraping, they actually cause a trauma to the uterine wall, and this causes the uterine wall to be thinner and at high risk. Then induction and augmentation of the pregnancy. This is usually done with citizen, and this causes severe contractions, and if there's any weakness on the uterine wall, it will cause rupture. Grand multiparity is also the thinning of the uterus throughout multiple pregnancies, as well as advanced maternal age. Once again, thinning of the uterine wall and advanced maternal age is just a risk factor for everything. So yeah, this is just a quick little summary of third trimester vaginal bleedings, whether it's painful or non-painful. You have your uterine rupture and your placental abruption, which is painful vaginal bleeding, and then you have your placenta previa and your vasa previa, which is non-painful. Then this is the protocol that's in the EB file. So this is a nice summary of basically everything I've said now. So it's bleeding less than 24, more than 24 weeks of gestation. If there is mild bleeding after intercourse, it's usually a local bleeding. But if it's more severe, then it's most likely coming from the placenta. There's also just emphasizes to never perform a vaginal exam without first excluding placenta previa. So as we see here, no PV until no PP. Then your
I'm going to interrupt. I'm going to interrupt you here. Don't go through the summary. The guys can to finishing your talk.
Okay, sorry, that is the last slide.
Oh, cool. Okay, you said you were going to share your resources with the team.
I'll put it in when I share it on the group. Sorry.
Okay, so let's put it out there. Then people can ask questions or make comments because we've probably only got 20 seconds left. Any questions? Any comments? Shame. I'm sorry to rush you. It's just because I know it's going to die.